Welcome, everyone, and this is RT Magazine's webinar on getting positive blood flow out of negative pressure at IPR therapy and the ITD. This live webinar has been approved for 1.0 CRCEs by the American Association for Respiratory Care and is sponsored by Zoll Medical. Today, we're joined by Dr. Eric Ernest from the University of Nebraska Medical Center. And my name is Mike Fratanturo. I'm the chief editor for RT Magazine. I'll be your moderator for the program. Here's just a quick look at our program today. So we're going to begin with some quick introductions. So we'll have a presentation by Dr. Ernest. We'll follow that up with some audience question and answers. You won't be able to submit any questions until later on in the show. There will be a little Q&A prompt control panel that will pop up. You'll be able to submit your questions in writing to Dr. Ernest, who will then be able to answer them for you. And then at the end, stay tuned for an exit survey / evaluation, which we'll use for attendance purposes. There'll be a link to a form that you'll be able to use. So don't, and just remember to stay online for the entire program. And also don't forget to complete the exit survey at the end. So with that, I'm pleased to introduce today's presenter. Eric V. Ernest is an assistant professor in the Department of Emergency Medicine at the University of Nebraska Medical Center. In addition to his faculty position at UNMC, Ernest serves as medical director for the state of Nebraska, where he oversees EMS services across the state.
Hello and welcome. My name is Eric Ernest. I'm an assistant professor of emergency medicine at the University of Nebraska Medical Center. For this webinar, we will be talking about intrathoracic pressure regulation therapy and the use of an impedance threshold device. And this talk is entitled Getting Positive Blood Flow Out of Negative Pressure. In regards to disclosures, I am a paid speaker of the Zoll Medical Corporation, otherwise no other financial interest to disclose. So the agenda for this talk is going to be going over a general kind of overview of the physiology of CPR, what we classically know about that I'm sure many of us have learned through our various AHA and CPR courses, and how we might be able to tweak that understanding just a little bit, and how that plays back into intrathoracic pressure regulation and also the ITD. We'll talk about how IPR therapy actually improves blood flow during low flow states such as cardiac arrest. We'll talk about how we deliver that therapy with the impedance threshold device. We'll also mention how to use the impedance threshold device. And then just some general kind of clinical overview and some practical application for this technology. So we think classically about how CPR circulates blood, and I think we're all pretty familiar with this concept that our classic model of cardiac arrest is that we're trying to compress that heart in between the anterior part of the chest wall and the sternum, and also the posterior part, which is the spinal column. And the idea is that we try to compress that, squeeze the heart in between the two, and then we're forcing blood out. And so the positive pressure that we're putting in the chest, that's what's causing the heart to empty, and then it's that negative pressure during the decompression phase or the recoil phase that is allowing that heart to refill with blood. And although this seems simple and kind of almost a little bit elementary, I think it's really important that we kind of highlight and keep in mind during this talk in regards to the decompression phase and how important that is and how much this therapy plays into the idea of how much blood we're bringing back into the thoracic cavity and subsequently into the heart, that we're kind of preloading or pre-priming that pump for the next time we do a compression on the chest, and how vitally important that is. So here's a little bit of a schematic in terms of looking at pressure inside the chest when we're doing CPR. So just to kind of orient ourselves a little bit to this graph, if you see on the kind of up and down axis, you have centimeters of water pressure, and that goes anywhere from -10 up to 30. And then on the axis is kind of over time. And so to look at these different pressure tracings, and this will kind of give us and set the stage for how this technology, again, plays into cardiac arrest. Anything above the 0 line is going to be positive pressure in the chest, anything below is negative pressure. And so when we think about what we're doing during cardiac arrest, obviously we're not only compressing, but we're ventilating a lot of the time. And so anytime we put a big positive pressure ventilation with a BVM, or if for some reason the patient's on the ventilator, we're putting positive pressure into the chest. And so you get a huge pressure spike when you do that. And then also chest compressions, obviously, like we just talked about, you have the positive pressure spikes every time you're pressing down on the chest. What I want to draw your attention to is kind of what is below the line and below zero. So anything that highlighting these little small red areas, we'd like to kind of associate that with blood return back to the heart. And so every time there's a chest wall recoil, we get a little bit more, or we have that negative pressure, draws the blood back in. And over time, as we're kind of working with cardiac arrest, and we've been doing compressions for a little while, this gradually increases. But really, when you look at this, we're not getting much more over, say, -2 to -4 centimeters of water pressure in terms of that negative recoil. And so this is really, again, the area where we're wanting to focus and how we can maybe maximize that blood coming back to the chest and then also increasing our preload. So classically, when we think about CPR, we know that this is a limited blood flow type state. Obviously, the heart is not working the way it normally should, and we're trying to augment that through kind of external compression of the heart. So when we look at some of the, when we're looking at pressure and flow models of how much blood is actually getting to our vital organs, really it's about 25 to 40% in optimal conditions of normal blood flow to the heart and brain. And so when you think about that, I mean, really, you know, we're not doing a phenomenal job at perfusing those vital organs. I mean, we're getting some things to it. It's helping with the gas exchange and metabolic processes, but really it's not where we want it to be. So when we think about why is blood flow limited during CPR, obviously the heart's not working the way it should, but we really have to focus on CPR quality as well. And that term does get tossed around in terms of high quality CPR. And when you really think about, you know, are you doing adequate rate, adequate depth, you know, and limiting how much pausing you're doing during a cardiac arrest, those things really can become quite complex in terms of, especially if you have multiple providers, it's kind of a chaotic or complex situation. Really, CPR quality is not an easy thing to master. And we also have to think about that when we talk about that negative recoil of the chest, that not only are we bringing blood back in the chest, but we're also getting air rushing back in through an open airway. So if there's nothing there to block the air, we lose some of the effect of that negative pressure and that recoil of the chest as air rushes back in. Also, we have to think about that for any of us who have done CPR, one of the things that you commonly feel when doing CPR, especially in, say, someone who's older, a little bit more osteoporotic or whatnot, that, you know, you lose some of that elasticity or the recoil of the chest when we start breaking ribs and whatnot during manual compressions. And so any of those things that where you're losing that recoil of the chest wall, all those things are affecting how much negative pressure you're generating. And we have to associate the idea that if we have less negative pressure, this is decreasing our preload, and again, how much we're loading that heart up for the next cycle of when we're compressing. So the question becomes, what if there's a way to enhance our negative interthoracic pressure? And again, that's kind of the big focus of why we're all here and talking about this. So the idea of interthoracic pressure regulation therapy is that we're trying to enhance the negative pressure and maximize how much negative pressure we can get inside the chest. And again, the idea, how do we improve that circulation of blood to the brain, other vital organs, kidney, liver, things like that. So that way that you get someone back, or the lesion is fixed in the heart that caused their initial cardiac arrest. Obviously, we want vital organs after that fact. So perfusing all these things during the course of cardiac arrest is obviously very important. So, and the one I mentioned next, so IPR therapy has actually been studied for quite a while. And this goes all the way back into kind of the mid to late 90s. And there's been several publications that you guys can see down in the lower left-hand corner there. But basically, kind of the nutshell or the takeaway from a lot of these things is what IPR therapy has shown to do. It increases preload. So we're going to bring more blood back into the heart to kind of give it that an increased volume to pump out the next time we're either compressing on the chest or the heart decides to beat on its own. Thus, we're increasing cardiac output. So good, again, more perfusion, and the ability to perfuse the vital organs like we're talking about. Some of the things that we don't quite think about, especially during cardiac arrest, but are also important, is that it also decreases intracranial pressure. So when you think about it, the big veins that drain the head and the neck, most of those do not have valves, especially the larger ones. And so we're relying on the idea that if we're creating negative pressure in the chest, it's going to kind of suck that blood back from the brain and the neck, and that's going to create forward flow of blood to the brain. So in effect, we are decreasing intracranial pressure by enhancing negative pressure inside the chest. And then overall, we do increase blood pressure. Again, that has to do with preload and cardiac output as well. So when we look at breathing, and this is during, if you think of how you normally breathe and some of the mechanics and the physiology of that, again, this goes back to how are we augmenting blood flow into the chest and whatnot, that when we inspire, our inner thoracic, or our thoracic cavity, expands. We create this larger space, which creates a vacuum, and that's what allows air to rush into our chest. And then when we decide to exhale, all those muscles kind of contract back down, the thoracic cavity shrinks, and that increases pressure, makes positive pressure, and that's what causes exhalation. And so again, we're trying to enhance basically what the body does naturally during the inspiratory phase. And this makes sense, right? So I mean, like if you're thinking about if you're working out or if you've exerted yourself, and when you start, say you go and run a mile and you start to breathe a little bit heavier and whatnot, your body is, taking those bigger, deeper breaths more often. And what it's really doing is not only for gas exchange of, oxygen and carbon dioxide, we're really enhancing, again, that negative pressure to bring more blood back to the heart because all of our organs are saying we need, better perfusion since we just exerted ourselves. So we're kind of harnessing what the body does naturally during a normal physiological state. So when we look at interthoracic and intracranial pressure, as I just mentioned, that these two things are vitally linked. That when we, just to kind of orient you to this graph here, so these are various pressure tracing curves. We are looking at interthoracic pressure, intracranial pressure, and then the subsequent aortic pressure and cerebral perfusion pressure. And basically, the idea is that when we drop interthoracic pressure, we see a noticeable difference in intracranial pressure as well. And you can see that kind of highlighted with that circle there. And so just kind of keeping that in mind that the more we can do this, the better perfusion we are going to get to the brain, and thus hopefully have less brain dead folks after their cardiac arrest. So how do we deliver this therapy? So obviously we'll need some kind of device or methodology in which to try to enhance negative pressure, because obviously if there's nothing on the patient, we kind of get the status quo of air and blood rushing back with really minimal to no negative pressure from the chest. So this is where the ITD comes in. So the idea behind this device is that this fits in line with the airway. And we'll talk about some of the applications later, but to know that right off the bat that this can be used really with any kind of airway device. So whether or not you're bagging the patient, you can create a very tight mask seal, and this will go in line between the bag and the mask. You can use this if someone has an endotracheal tube in place, some kind of supraglottic airway, whether it be like a King airway or a LMA or something of that nature. Can also with the supraglottic device and endotracheal tube. So really can be used with any of those devices. And the idea is that it serves kind of as a one-way valve that, and we'll see this in subsequent slides, but the idea is that we're going to try to stop air from rushing back into the patient during that recoil phase of cardiac arrest. And what that will hopefully do is, as opposed to bringing air back into the chest, that negative pressure is going to draw more blood back into the chest. So we really have to think of an ITD as a circulatory device, although it does sit kind of in the airway stack, if you will, and these can be quite tall depending on how many devices your hospital or pre-hospital system uses in terms of end-tidal CO2 and whatnot. But really the idea is that this does sit within kind of the airway management device chain, if you will. But really we have to think of this as more of a circulatory device, and that it really is enhancing blood flow. And has probably a little bit less to do with airway as it does more so circulation. So just so you guys can kind of understand how this works, and as I mentioned, it does act as a kind of a one-way valve. So looking at the different phases of cardiac arrest, and we look at kind of airflow through the ITD. So when there's chest compression, we have to remember, again, we're creating positive pressure within the chest. So the air can get forced out through this, and the patient can also, if for some reason they had ROSC, we didn't recognize that, they can freely exhale through this device as well. And then we also have to look at the the other phase of cardiac arrest. So say we're ventilating the patient, there is a seal, if you will, that can be broken temporarily when you apply a certain amount of positive pressure with the bag valve mask to kind of be able to force air past the one-way valve into the patient to be able to ventilate and oxygenate the patient. So, and going on, so chest wall recoil, this is really kind of where this device is performing at its best here in terms of when that chest recoils, you get that negative pressure. Because we're not applying a ton of positive pressure, as I just mentioned in the previous slide, what the device will do is kind of seal off or block any incoming air coming back into the chest. And this is where kind of the vital component of what this does and why interthoracic pressure regulation can work is that air is not coming back in, enhances the vacuum, you get more vacuum in the chest, and thus better blood flow back to the heart. Now let's say the patient, as I mentioned, does have return of spontaneous circulation. They're breathing on their own, and they want to start, trying to inhale. They can still do that. A common misconception is that we put this on the patient, and all of a sudden, the horrible feeling that if they were awake, they can't breathe because there's this valve that's not allowing them. You can breathe through it. It does take a little bit more effort, but if you can at least generate negative 10 centimeters of water pressure, that it will allow for spontaneous breathing through the device. So I think that's important as well. So going back to our pressure tracing curve and kind of remembering, above and below that 0 mark. So conventional CPR, we kind of already went through that and oriented you to that graph. Now, if we add in the impedance threshold device, again, we have our big spike here, up to 30 centimeters water pressure with ventilation, and then going back into our compressions. What this does is that as we progress through our cardiac arrest, we're able to generate more and more negative pressure with the ITD. And as illustrated by kind of this area under the 0 line mark, we're getting more and more of an enhanced vacuum, more and more blood back to the heart, and thus increasing our preload. So again, just looking at this in more of a number type format. So if we're looking at conventional CPR on the left here, we're generating, anywhere from, 30 to 50, probably right around 40 millimeters of mercury in terms of pressure with conventional CPR. Again, that's limited by the fact that our preload is limited as to how much blood is coming back in the heart. And so really we're not generating a ton of pressure. So 43 during the systolic phase, which is when we go and we perfuse, all the vital organs, we're sending blood to the brain, et cetera. And then during the diastole phase or the chest wall recoil phase, we're only getting about 15 millimeters of mercury. And the important thing to remember, and again, the recoil is kind of what I'm going to keep focusing back on. If you remember to your basic kind of anatomy physiology, the recoil or diastolic phase of the heart cycle is when the coronary arteries are perfused. And so if you have someone who has blockages within their coronary arteries already, to know that try and generate as much of that diastolic pressure as possible to try to push blood past the clot and try to perfuse the heart as much as possible to hopefully get them back out of whatever their arrhythmia is. So when we jump over to the right side of this and look at CPR with an ITD in place, we can see that, again, we're increasing that preload. So again, there's more blood for the heart to pump or when it's compressed. So we're increasing cardiac output, and we're thus increasing our systolic blood pressure, so up to about 85 millimeters of mercury. We're also enhancing our diastolic blood pressure, which again is going to be better perfusion for the heart. So really a marked increase for both systemic perfusion as well as perfusion of the heart. So just to kind of orient you a little bit to the device, there up on the top here, there is a little timing light switch, which does allow for timing out of ventilations. To remember that it's important to make sure that we're not overventilating our patients, which is a very, very easy thing to do. This will basically flash every time you need to give a ventilation, which should hopefully limit the overventilation, of the patient. Then the impedance threshold part, which kind of sits in the middle, and then there's the low resistance respiratory valve, and where you kind of connect it to the rest of the airway circuit there on the bottom. So, like I mentioned, there's the switch that turns on these kind of flashy lights that tells whoever is ventilating the patient when to ventilate. These will flash at 10 times a minute or about every 6 seconds. And again, this The slide says used for advanced airway. Again, this could be really used with in line with bag valve masks as long as you do have a good mask seal, your supraclonic airway devices, as well as your endotracheal. So in regards to the face mask, if you were in kind of a basic rescuer mode, or say that you didn't have an advanced airway established quite yet, you can use this in a two-rescuer operation where basically your person at the head will create a two-handed tight mask seal over the patient and kind of leave the bag just kind of hanging, if you will, while the other person's compressing. And then that person who's compressing, if you're doing like 30 to 2, can reach over and give ventilations. And this person up at the head of the bed, though, is important that they maintain that tight mask seal throughout the entirety of when this patient or when the other person is compressing. Because again, when they're recoiling, we're relying again on the ITD to stop that inward flow of air during the recoil phase. So there's also some, a device that you can use to kind of help maintain that seal. There's a head strap that can be used if you're, in a limited situation where you may only have one rescuer. So when we're using it with advanced airway, obviously we always want to make sure the endotracheal tube is in the correct position, usually confirmed with end-tidal CO2. We'll connect the ITD to the end of the endotracheal tube and then connect the ventilation source, usually a bag valve mask, but it could be a ventilator. And then we'll continue to do chest compressions. And usually at this point we'll kind of switch over to continuous chest compressions. And then we'll flip on that timing light and be able to ventilate kind of asynchronously. So basically you're trying to do that about 10 times a minute. Obviously, you don't want to try to ventilate while the chest compressions are going on. It'll be very hard to do that. But usually being able to kind of squeeze ventilations in during that recoil phase of cardiac arrest. So a common question that comes up in terms of, can we use end-tidal CO2 with this device? And the answer is most certainly yes, and I would always encourage end-tidal CO2 monitoring with an advanced airway. Also kind of helps you monitor how well you're doing during your resuscitation. But the placement of this, most of these kind of inline sensors, and obviously there's many different models, and people have different types of equipment at their facilities. But basically, whatever your sensor is, would go on top of the rescue pod. So basically, down at the bottom, you have your airway device. It hooks into the rescue pod or the ITD, and then the end-tidal CO2 sensor would go above that, and then your ventilation source above that. So, in terms of some of the clinical features of this, so obviously we've talked about some of the benefits when it comes to low perfusion states like cardiac arrest. This can help. It's a non-invasive thing that will increase overall circulation, help with cardiac output. It works. There's no fluids. We're not giving any kind of medications or fluids. Obviously, I give those anyway during cardiac arrest, but it's not needed to make this thing work. It does help promote proper ventilation rate, which obviously, if you go back to if you think back to that graph, if we're overventilating that patient, we're putting in those huge volumes and pressures with our bag valve mask. All that time spent above that zero line are times that we're not getting that good preload back. So really making sure that whoever's ventilating is ventilating at the right rate is also vitally important for cardiac arrest. The device is latex-free for any concerns regarding that. It is meant as a single patient use device, cannot be sterilized or reused, and then it is compatible with mechanical CPR devices as well. So some of the reminders, if we do get ROSC on the patient, as I mentioned, the patient can breathe through it, although it is a little bit more, it takes a little bit more effort and probably not as comfortable. So if you do get ROSC on these patients, just to remember to remove the ITD. And then if you get fluids or secretions in the device, you can blow it out using a ventilation source of a bag valve mask, and that can usually clear out some of those secretions. And then we had already talked about the ventilation guide with the lights, and then using kind of all these thoughts or these techniques will hopefully give us our best chance of outcome and allowing the IT to do what it is meant to do. So let's talk a little bit, so obviously this is a device, and anytime, I've given this talk several times in multiple different venues, and always the question becomes, oh, this is something new, or I haven't heard of this, or, why is it my hospital using this or my EMS agency using this or whatever the case may be. And just to remember that, that a lot of these institutions will require that there's something that backs all this up, that we've actually tested this in the lab and in a clinical setting. So we'll kind of go through a little bit of the evidence for that this does in fact work, and go through some of that with you guys. So as I mentioned, a lot of this work goes all the way back into the late 90s, early 2000s, where some of this was kind of being developed. And so some of the preclinical and early clinical research that was done during cardiac arrest with the use of the ITD, we know that it does multiple things. So it doubles end-tidal CO2. So when you think about the low-flow state of cardiac arrest, we're trying to enhance cellular metabolism, and one of the byproducts of that is CO2. And so, you can see that when you get ROSC as well, that everything kind of restarts back up and you get the jump in CO2. We really want to, when we look at CO2, that's really kind of a marker of how well we're getting metabolism or respiration at the cellular level. So increase in end-tidal CO2 is good. It was noted to double blood flow to the heart, so again, good perfusion of the coronary arteries and the actual muscle of the heart. Again, blood flow to the brain, very, very, very important. Increasing that by about 50%. Lowering ICP, again, we talked about kind of that forward blood flow to the brain and its ability to lower that ICP as we decrease interthoracic pressure. Doubles systolic blood pressure, and again, the early clinical stuff was showing that it increases survival by 25% or more. We'll go through some more here. So one of the big studies that was published in Resuscitation all the way back in 2002 looked just simply at blood flow to the heart with the ITD, and it showed, the SCPR stands for standard CPR. So again, we're not using any kind of mechanical devices, really pretty, basic cardiac arrest management. And so when we looked at this in terms of the blood flow rates, we were actually had about 93% improvement in coronary perfusion and whatnot with the use of the ITD over standard CPR. Then looking at another critical organ, the brain, we did see that there's a 50% increase in blood flow to the brain with the ITD, so comparing that to standard CPR. And then looking at end-tidal CO2, about an 81% improvement compared to just standard CPR. So again, some of the big things that we're really trying to measure and care about during cardiac arrest, all markedly improved with statistical significance with the use of the ITD. Again, systolic blood pressure, this was published in Resuscitation 2005, basically a 98% improvement over standard CPR when the ITD. And then some of so people are saying, okay, well, that's great. We can study this in the lab. We can use pig models. We can use, early human models and, look at this. But, when the rubber really hits the road, we can increase blood pressure. We can decrease ICP and all this. But, what we all really care about is that our patients are able to leave us and actually go home and lead a normal life. And so when we look at survival, and this is for in-hospital cardiac arrest, ITD, so we're assuming that most of these patients, it will be a relatively witnessed arrest. This is someone out in the community who's been down for 10, 15 minutes, so that, these are in-hospital arrests. If you look at just all comers, so all patients, we notice, a jump in terms of percentage to survival, survival to hospital discharge, going from 17.5 all the way up to 28%. And then if we look at patients in PEA, that subset, we have a jump from 14.4 to 29.7. Again, marked improvements with use of the ITD over standard CPR. And you're all saying, okay, well, that's great. We got them out of the hospital, but, did they come back within 10 days and they end up dying or whatnot? How did we do in terms of long-term survival with these patients? So when we look at all comers, so this includes all of our VFib, VTAC, PEA asystoles, we still see marked improvement from 10 to 13%, or a 30% improvement, for all comers. If we look at the ones that are probably the most salvageable in terms of a initial presenting rhythm of VFib or VTAC, we see a 61% jump from standard CPR. And then looking just at, do these people have good neurologic function? Because obviously if we're discharging them to a long-term care facility and there's some kind of vegetative state or not able to care for themselves, obviously we want better for our patients. So those who are having good neurological outcomes, they can go, they can function, they're back in their communities, seeing a 79% jump for good neurologic function and discharge with ITD. So looking, and this is the people, especially on the hospital side, and sitting on a couple of hospital committees myself, this always gets brought up in terms of the economics. So there's a study that was done in critical care medicine back in 2011 that looked at 350 out-of-hospital cardiac arrest patients. And when they looked at the ability to discharge these people with good neurological outcomes, the overall survival of the hospital discharge more than doubled after following good AHA guidelines, and that also to the ITD. And then what the folks upstairs, so to speak, really care about is that when you look at hospital, the margins and how much money this is making the hospital, that you're increasing that by more than $20,000 if the patient actually survived to discharge. Which obviously most of this talk is supposed to focus on clinical and doing the best for our patients. But if you have that hospital administrator being like, okay, so why am I going to buy this and put this on all my code cards, and and looking at this huge economies of scale of employing a new device, there is some real world numbers to go along with that to say that this actually will affect the hospital's bottom line, and it's good not only for our patients because they can have them go home, but this is also good for the economics of the hospital as well. So let's talk real quick about the 2015 AHA guidelines and the ITD, and this is where I think there's been a bit of contention in regards to the use of the ITD and some of the recommendations that came out. And so we'll go through some of this and kind of help you navigate this. So for those who have been doing this long enough, and we remember back to 2010, there is the recommendation that the use of the ITD may be considered as a CPR adjunct in adult cardiac arrest. That was a level 2B recommendation. So back 2010, when a lot of this data and the research was coming out, we're like, okay, this is getting incorporated into cardiac arrest, great. We're going to use this device. Hopefully we'll see good outcomes, and all is well. Well, then 2015 came around, and AHA does what they normally do, and they update all their recommendations. And the ITD got a little bit singled out here. In terms of, they came out and said the routine use of ITD as an adjunct during conventional CPR is not recommended, which got a Class 3 rating, which shows no benefit. That's basically saying that there is no high-quality evidence that demonstrate a benefit or harm associated with the ITD as an adjunct to conventional CPR. And for those who were kind of deep into this and who had done a lot of the original research and the developer of this, we're all kind of scratching their heads being like, well, gosh, in our preclinical and our clinical studies and also just in common practice, we're getting the sense that this thing is actually doing what it's supposed to. And, how did the AHA kind of miss the boat on this? And so when we really dig down into the kind of how they define and come up with the recommendations, we need to look at a couple things here. So AHA had actually expanded its definition of Class 3 to include two new categories, one of which was no benefit, and the other one was harm. And so basically they put the ITD not as a harmful device, but basically saying this really doesn't convey a benefit, so you don't really need to use it. They did, however, keep in a Class 2A recommendation, which means that that there is some use in the timing lights. Well, there's a lot more to that device than just the flashy lights on top. That there is a physiological effect that this device is having. And so, so why was there this change in the recommendation? So when the AHA goes through and does their guideline recommendations, and when they publish their updates, they will go and they will survey and gather from the body of medical literature the studies that pertain to this. And back in 2010, they had about 15 studies that they drew on to come up with their recommendations. And then when they fast forward to 2015, there was only 3 studies that were considered. And one of which it was a huge trial, multi-center trial. This was funded by the federal government. Just a massive trial called the Rock Prime Med Study, which was done. The primary author was Dr. Heidi, and it was published in 2011, New England Journal of Medicine. And this study was basically kind of looking at everything to do with cardiac arrest. There's multiple sub-studies that came out of that study, and it was kind of to try to encapsulate all that surrounds cardiac arrest. And so when they looked specifically at the impedance threshold device from this study, they analyzed about 8,700 patients. 4,300 of those randomly assigned to treatment with a sham ITD, meaning something that didn't work, and then 4,300 to the treatment with the active device. And so you had 260 of those patients, or only 6% in the sham ITD, and 254 patients, or 5.8, in the active IT group met the primary outcome. And basically, looking for, did they survive from their cardiac arrest, and what was their outcome and whatnot. And basically, they said, when we're looking at all these patients and all comers, it's just not showing overall, improvement in survival, and they're all out of hospital cardiac arrest patients, so you're a little bit behind the 8 ball with those folks anyway. But basically, this did not improve survival, and they couldn't recommend it. Well, so it's saying, why did this show neutral results? Why did we not see the outcomes that we all had expected that we were going to see with the device? And so really, going back to what I originally mentioned in the talk, we really have to think about cardiac arrest, that there are some sweet spots of cardiac arrest, that we can't just kind of just jump on the chest and compress at any rate we want, can't go at any depth we want, looking at ventilations, that there really is some, the points that we really want to focus in terms of high quality CPR, really that's what we need to focus on, that group of folks who are actually getting the therapy that they need. And so when they did a analysis of the data, they came to find out that there actually is an optimal range in terms of chest compression rate for survival. And so these graphs basically show that as you start increasing your compression rate above kind of the 115, 120 mark, your survivability from cardiac arrest drops off precipitously. And so the idea is that if we take the patients who actually got a good rate, a good chest compression rate, and that's anywhere from about 90 to 120-ish chest compression rate, and that's anywhere from about 90 to 120-ish, those patients we would theorize would have the highest benefit of survival. So we took some of those patients and found that not only a lot of patients that get inappropriate rates of CPR, but that we did see that survival is directly related to chest compression rate, and seeing again that was best between 90 and 120. And so basically what they did was a post hoc analysis of the ROC data, and when all this came out with the AHA. And they found that if they started to isolate that data set and really look at some of the key factors, I'll not go through the slide, and this may be a little confusing on the outset looking at, but if you look at the first graph, the 12% part, and if we looked at patients who had chest compression fractions of greater than 50%, and chest compression fraction means that if you took a minute of CPR, that there are hands on the chest doing compressions for at least 3 seconds that are greater than 50% of the time. And so if we just took the patients that had that, we're not worried about the rate, we're not worried about the depth, all we're worried about is actually people keeping the hands on the chest and actually doing good chest compressions, that we would increase our functional survival to hospital discharge with use of the ITD by 12%. So we're saying, okay, gosh, we're getting our hands on the chest, we're doing more CPR, we're not having all these pauses and whatnot. Even just doing that with the ITD, we've increased 12% off of our baseline. They then took that a step further and said, okay, let's actually look at some of the parameters of cardiac arrest and how to do this well. So they said, let's take a group where we knew that the compression rate was 80 to 120 per minute, and that they were compressing at a depth of 4 to 6 centimeters. So that second group, they showed a 36% increase with the use of the ITD. Getting good CPR, we have the device in place, we're seeing a marked increase of 36% with good CPR. Then if we combine those two, we're saying, okay, not only we're keeping hands on the chest, we're minimizing interruptions, but then we're also doing good quality CPR, and then adding in the impedance threshold device, that jumped our survivability up by 76%, which is just absolutely huge. And so I think this really goes to show that the original analysis of the data that the AHA did, they kind of took all comers of all different qualities of CPR, and basically, if someone's going to get compressed at 60 a minute or 200 a minute, they're probably not going to survive no matter what you do. But if you really hone in on the group that got good quality CPR, hands were on the chest, the majority of the time, and you added in this additional device to help with that preload and enhancing negative pressure, we're seeing marked increase in their survivability rate. And so for anyone that wants to read this article, I think this is kind of the big key one, especially when someone argues that, oh, we shouldn't be doing this, the AHA and what they put in their 2015 recommendations. The resuscitation article by Yiannopoulos that was published in 2015, really I'd point people in that direction because that really kind of encompasses kind of the argument against what AHA had already mentioned. So a couple of other things that came out since that time. So if we're looking at witnessed cardiac arrest with high-quality CPR, again, this is kind of mimicking what we already have kind of talked about and what we know, that if you're using a sham or a non-active ITD versus active, we're seeing a jump from 7.4 up to 11.9, so 61% improvement in functional survival. And so some of the kind of the key takeaways, you know, and I already mentioned this, but again, high-quality CPR is really what's important. If we can add in some additional tools like the ITD, we're going to increase our chances of survivability that much more. So, and I think we all know this from the various classes and just kind of practical experience, but, you know, at the moment we know someone's in cardiac arrest, we, you know, start chest compressions as soon as we can. We want to avoid interruption, so if we can keep our hands on the chest for more than 80% of the time or higher, that's great. You know, minimizing things like, you know, unnecessary pulse checks, airway management, things of that nature where we're stopping CPR, realizing that that is not helping the patient and that high-quality CPR is what's going to save that patient. Compressing at the correct rate. So although not the focus of this talk, but having some kind of timing device or something, some kind of feedback device, always important when doing chest compressions, whether it be a metronome or something with, you know, your cardiac monitor to say that you're going either too fast, too slow, and not the right depth. Making sure that we're pushing hard. Again, you know, it's a little bit difficult. No one's getting a ruler out to measure this, but there are feedback systems with various monitor companies that can tell us exactly how far we're, you know, compressing with accelerometers and whatnot. So making sure that we're getting good depth of compression. Allowing complete chest recoil. If you ever watch someone, especially someone who's doing manual CPR, and if they're not switching out enough, we kind of sorts of things, but if we have constant positive pressure, really the patients are not going to do well. Not hyperventilating, we already talked about that point, and then use of, you know, the tools that you have in front of you, so make sure you're using timing lights, and we already talked about CPR feedback. So with that, that concludes the talk. Again, we're going to have some time for some questions and whatnot and be able to discuss it, but my contact information is located on the last slide. If you want to contact me individually, I'd be happy to talk about any of this. And with that, that concludes the presentation.
Great. Thank you, Dr. Ernest. We're going to have time for some question and answers here. I'm just going to queue up the slides again real quick. 1 second. Before we get to the Q&A, I just want to have a message here from our sponsors. So Zoll Medical Corporation develops and markets medical devices and software solutions that help advance emergency care and save lives while increasing clinical and operational efficiencies. With products for defibrillation and monitoring, circulation and CPR feedback, data management, therapeutic temperature management, and ventilation, Zoll provides a comprehensive set of technologies that help clinicians, EMS and fire professionals, and lay rescuers treat victims needing resuscitation and acute critical care. For more information, visit www.zoll.com. So right now I'm going to queue up a little Q&A manager here. You'll have the opportunity to fill this out. These written questions will go to Dr. Ernest here, so please feel free to fill out if you have any questions for him about any of the slides or just the general therapy or the device. Please fill those out, let him know. Dr. Ernest, if you could, if there's anything else you'd like to just, you know, while people are filling out a couple questions, if there's anything else you'd like to, you know, recap or add from the presentation today.
Sure. Michael, can you hear me okay? Is the audio sound?
Yeah, great. Yes, definitely.
Awesome. So I just want to, first of all, thank everyone for hopping on and joining the webinar. I think I think what's interesting, especially working both in the hospital and pre-hospital side, is that when we are classically taught cardiac arrest management, CPR, whether you went through the AHA or some other course to learn your basic CPR technique, the idea of interthoracic pressure regulation, I think, is a topic that has a high impact yet is really not taught in common practice. We talk about some of the metrics of CPR and whatnot, and all those things are great, but I think really harnessing some of the body's own natural physiology to try to enhance blood flow during cardiac arrest, I think is when I give this talk, and especially for people that have never heard of this concept or are not familiar, it does make a lot of sense from a physiologic standpoint. So I mean, and really, I would encourage you that if there's any questions, certainly we can answer them here. But that if you're not, if you as a person or you as within your institution are not familiar with this, I really encourage you to bring this back to your place of practice, because I think it really helps better conceptualize the tenets of cardiac arrest and kind of what's happening during that compression and decompression of CPR.
So we do have one question from Betty. She just asked, like, what's the typical cost for this device? And I guess not just for one. I guess implementing it across your your department. Like, what kind of investment are people looking at? Maybe.
I think that's a good question. I think it's all going to depend on volume pricing. I would always encourage you to contact a local Zoll representative for sales. I will tell you, with my local EMS agencies, we're paying right around my large EMS agency. I think we're right at $90-some odd per unit, all the way up to about 110, 115. Again, I think that's going to depend on volume pricing. Don't quote me on that. I don't work for Zoll sales, but I think it's right. If you get ballpark right around $100 per unit, give or take.
So we have another question related to the product. What's the shelf life of the device? I guess how many patients can use it for, and on.
Yeah. So it's a single-use device. Shelf life, that's an excellent question. I don't know what the expire date on it is. I would imagine it's rather long. There's not really any parts that necessarily decay, or it's not a fluid or a medication. So without having one right in front of me, I don't know the answer of total shelf life, but I would imagine on the order of multiple years. And actually, my Zoll rep who is listening in, she's telling me 4 years. So it sounds like that's where we're looking shelf life-wise.
And one other question from Catherine is the device only for adults, or it can be used for pediatric patients?
I think if I'm not mistaken, I think it's approved down to the age of 12, if I'm not mistaken. I mean, most of this is going to be played out in adult cardiac arrest. But I think that's where most people use it down to. But I think technically, according to Zoll, that there's no technical age limit, and really it's at the discretion of the physician, especially for EMS, whoever's having physician oversight over the agency. And my Zoll rep is also telling me that it can be used, in fact, in pediatrics. So we're really any range, but kind of up to local medical direction, or if you're working within a hospital, what they decide, patients.
So two questions. I'm going to kind of try to combine them because they're about the functionality of it, I guess. One's from Lisa and another one from John. Lisa asks, is device similar to a PEEP valve? And then John asks, how much does the device add mechanical dead space, and if so, how much?
So I'll take the mechanical dead space question first. I mean, this is a relatively short device, so I mean, I don't have the specific volume measurement, but I would say it's a minimal dead space additive. In regards to what was the first part of the question again? Sorry.
Is the device similar to a PEEP valve?
Oh, to a PEEP valve, right. So no, the sense of a PEEP valve is the ability to increase your end expiratory pressure. This is almost like the exact opposite of a PEEP valve. This is, when you think of a PEEP valve, it's that ability to keep the end expiratory pressure higher, especially whether you're doing manual bag valve mask, or if you have them on a ventilator. This is enhancing negative pressure, so we're swinging that pendulum to the other side of kind of that curve of the equation where we're enhancing negative flow. So it's kind of like the reverse or negative effect of a PEEP valve. You're putting something on there to enhance negative flow. So, and I'm getting from the Zoll folks 41.2. I'm assuming that's cubic. that or 41.2 Cs for dead space. I think she's trying to say.
All right, so another question there from Jennifer. She just asked for just if you could explain again how the device blocks air and encourages blood return to the lungs.
So the idea is that, so just kind of in quick review, that we're focusing mostly on the recoil phase of the chest. So it's, if you think of kind of like a bellows, something that, kind of like what you use to fan a fire, that, when you push it together, it pushes air out and kind of fans the fuel or the fire, and then when you open those bellows up, it sucks air back into the bag or into the bellows itself. So similar with the chest, as that chest expands or recoils out of the compression phase into the decompression phase, that opening up of the chest creates a negative vacuum and negative pressure, and that's what allows both air to rush back in through the mouth and through the trachea into the lungs, but that negative pressure is also kind of sucking blood back from the periphery into the right side of the heart. And so what we're trying to do is, so if you're competing for negative pressure, so you have a competition, if you will, between air and blood getting back into the thorax, what we're basically doing is putting a valve in place that does not allow passive flow of air during that negative recoil phase. The air gets blocked, and so we're using all of that negative pressure that the chest is generating in the recoil phase to instead of bring air back into the chest, which really doesn't help us all that much, and instead bring blood back to the right side of the heart so that we can increase preload, and that will affect how much blood is being pushed out on that next compression of the heart.
Okay, and one other question about the actual device from Margaret, and she said something, you mentioned there was a light that triggered, the light feature. She asked, does that affect, the shelf life? Do you have to replace the battery on it or anything like that?
I'm pretty sure that the battery in that is rated for the shelf life of the 4 years, and so it's nothing that you'd have to go, replacing a battery on. That the battery would be good until the shelf life expires on the device. And the folks from Zoll are saying that's the reason for the shelf life, that battery is good for about 4 years on the shelf. And again, it's single patient use, so once you put it on the patient, there's a little switch that you kind of roll over or switch on, and that will then start that the timing light going out or going off about every 6 seconds to give you about 10 breaths per minute, which is recommended ventilatory rate.
Okay, if anybody else has any other questions, please fill them out. Let us know. I think that does it for the ones that are there, but just if you have a last minute question here, we have time just for like one or two more. If anybody has anything else they want to ask Dr. Ernest before we conclude the program. Well, Dr. Ernest, I'd like to thank you for joining us today. I thought it was a very informative presentation. It seemed like a lot of people got a lot out of it. We had some good comments, and during the chat function, hopefully everybody was able to stay tuned, without any too much technical issues. But anything else, Dr. Ernest, you'd like to add? Any concluding thoughts or anything before we wrap up?
No. I will say, like anything, cardiac arrest management is a multifaceted kind of game, if you will. That there's not one thing that I think we do in cardiac arrest that's a silver bullet to all of a sudden jump our outcomes. I think it's a good system of care. It's the providers working on the patient. It's a combination of good high-quality CPR and use of appropriate adjuncts like the ITD. That combination of everything is, I think, where we see betterment of outcomes overall.
Okay, great. Thanks everybody for joining us today. Don't log off just yet. There is going to be an exit evaluation form. There's a link here on the screen. Don't worry, you don't need to type that out. I'm going to pop one up on the screen for you that you can click on, and it should take you directly to it. Here, you're going to see that pop up in 1 second here. Okay, you should be seeing a little link on your screen there. That's the link for the evaluation form. In addition, when I close the window out here, you'll be automatically redirected to it. So if you leave this window open, as soon as I end the webinar presentation, the window will then transition to the evaluation form. It's just a Google form. It has, maybe 4 questions on it. But please fill that out. We use it for, for attendance purposes and also for evaluation for it. If there's anything you need to contact us for, I've included Dr. Ernest's contact information here again, as well as mine. If you have any questions about the webinar process, the certification process. So please fill out the evaluation form. And then once we collate the data from that, we will be getting a certificate over the email address that you provided. This is for the CRCEs, so if you're interested in those, we have your registration information, but please fill out the exits evaluation. And you can contact me if there's any questions. You can contact Dr. Ernest at the information here if you have any questions specifically about the therapy or the device. We'd also like to thank our sponsor today, Zoll Medical, for making this happen. You can find out more information on their products at www.zoll.com. So thank you, everybody, for joining us. We're going to conclude the program now. I'll leave the screen up just for a minute, just so you can get the link. But also, again, if there's any issues, you can always email me at editor@rtmagazine.com, and I'll help you get through the process. Great. Thanks, everybody, for joining us today.